my name is Holly Costello. I'm one of the midwives here at Adriatica Women's Health. The topic that I would like to share and talk about today is advanced maternal age and pregnancy. And so what you'll hear kind of commonly, things that people refer to it as often, is geriatric pregnancy. I usually like to tell our women that is actually not what we use. We do not use that term to identify your pregnancy. And it's actually not because you're old. It is because there are certain risks and things that change as women come into advanced maternal age. That starts at age 35 or older. And how we look at that is, again, it's not that mom is older, it's that keeping in mind that women are born with all the eggs they're ever going to have. So we're looking at that based on the age of the egg. And so again, it's not really about mom's age, it's about the age of the egg. And we think about that again with women who have like IVF pregnancies and things. How old was that egg when it was retrieved? Because then that's sort of how we look at these risks as well. And so we have some categories of advanced maternal age that we sort of cluster that age group together and we think about. One is sort of just when you meet that criteria at 35, and this is based on the time you deliver. And so you might start your pregnancy at 34, but your due date could be when you're 35. And so if that happens to be you also fall into this category of women. So there's sort of 35 to 39, and we sort of look at those women in one lens of risk. And then we have the women who are 40, and then the women who are 45 or older. And we think about it that way often as providers because the risks seem in the numbers for things that can happen go up with those different age groups. So advanced maternal age. So again, we're talking about women who are 35 or older in pregnancy. And so I like to start out and tell you sort of what things are going to come along in order of the pregnancy. And so when we think about first getting pregnant, one of the first things we have to think about is risks of miscarriage. And I know it's a kind of crummy topic to talk about, but those rates do start to go up for women 35 or older. They are quite a bit higher for women who are 40 or older. And so when we think about risk of miscarriage, there are things that happen in pregnancy, we sort of call them on like a J curve, meaning women that are affected can be in the very young or the very old, if you will. And so the sort of lowest miscarriage risk for women are in their 20s and 30s. And we estimate that somewhere around like 10 to 11% of pregnancies. And so as we get a little bit older, those risks do go up a bit more, around 35 to 39, that those women falls into about 17%. And then when you get into the 40 or older is around like 33% was the last literature that I looked at. And so you can see that as you age, those risks go up. So we do an ultrasound when women first come in, but that means that they haven't had anything to tell them that there might be something going wrong in the pregnancy, like a miscarriage. Sometimes there are very obvious signs like bleeding and pain, and sometimes there's not. And so we always do an ultrasound when women come in for their first visit. And so sometimes that is bad. A bad thing that sometimes happens is that the pregnancy didn't continue, and that we have to then talk about miscarriage and maybe why that happened and help them develop a plan for that. So I know we're mostly talking about pregnancy, but I do think that that's something really important to share too, because I think it's a really tough thing that women have to go through. The other thing that comes up is the risk for twin pregnancies or multiple gestations goes up as we age. And so of course, when we think, well, we do that ultrasound when you first come in, that we do for viability, but we're also checking to see how many babies are in there. So that's kind of something to expect. We do that for all of our patients, but not every practice does that. Sometimes you just date based on last menstrual period and you go forward with the pregnancy as long as you have reliable dating for that. But we actually do a first trimester ultrasound at all of our new OB visits, but it is recommended women 35 or older always have that. And then when we go forward just a little bit more in the pregnancy, one of the things that we like to talk about is the risk for chromosomal abnormalities. And so that does start to go up at age 35, and it does increase quite a bit more from that at 40 and older. And so all women 35 or older are recommended that they receive NIPT. And so what that means is non-invasive prenatal testing. The non-invasive part is that it's a blood draw on mom that we pick up fetal fraction of DNA and we analyze and look at that for chromosomes. Now, we don't do it here at Adriatica. That is something that is sent out to a very reliable genetic testing company that we use, and there's a few out there, so I'm not going to name specifically who we use, but they're a great company. We've done business with them for a long time. They're very, very reliable. So we have that blood drawn, we send that out into a kit that goes to that company, and then they look at chromosomes on baby. And so it screens and looks for common things that people think of as Down syndrome, but it does check for other different trisomies. Other next common ones are trisomy 18 and 13. So we screen all of those chromosomes in addition to sex chromosome abnormalities, again, just because of those increasing rates. And so that's something that will come across around 9 to 10 weeks of pregnancy that we recommend women have that blood drawn. Now, I would like to stop for a second and say that we always are going to have recommendations, and our job and our role is not ever to tell our women what to do. Our job is to give them information, let them know why we have that recommendation, and then let them decide what it is that they want to do. Because certainly we have women that elect not to do maybe some of these recommendations that come across along the way. And so we support our patients, whatever their decision. We just want that to be an informed decision. And so we want to make sure we give them all that good information. As we journey a little bit more into the pregnancy, we get into the time where we do anatomy surveillance on babies. And that generally happens somewhere around the 20th week of pregnancy, maybe a little bit before, a little bit after. And it is recommended that babies receive a detailed fetal anatomy surveillance ultrasound versus a basic anatomy ultrasound. And the reason for that is there are increased risks for different type of like heart defects and different types of like congenital cardiac disease and kidney issues and different things. So there are certain things that we see at increasing rates as women age. And so we do have a recommendation that we do a more detailed ultrasound for those patients. Now, for us here at our office at Adriatica, we don't do those types of ultrasounds here in office. That's something that we recommend our patients see a maternal fetal medicine specialist for, so that they have that really high quality ultrasound on their baby with them. And that's the reason we give that recommendation. As we journey a little bit more into the pregnancy, we get into third trimester, and there's some recommendations that we have for something that we call antenatal testing. And so antenatal testing is two different parts that we look at as fetal well-being surveillance on our babies. And so we have a non-stress test, which we commonly call an NST, and that is where we have the little straps and the monitors that we put on mom's belly. We have two different monitors, one that is just watching for the uterine contractions, and then one that monitors the baby's heart rate continuously. And we do those here in our office, and we do those generally, if we pick up the baby in the perfect spot, then we usually will get about a 20-30 minute time frame that we can get reactivity and certain things that we look for babies to tell us that they're doing well in utero. And then sometimes we pick up babies in rest cycles. So I like to tell moms, be prepared. Sometimes you might be here for 40 or 50 minutes for us to get that strip of reactivity if we picked up a rest cycle combined with that. And then the other part of that is called a BPP. So it's an ultrasound. And so it's an ultrasound that looks at 4 different points. We actually call this whole thing like 10 out of 10 points, but we combine the NST for 2 of those points. So the BPP is looking at the other things that we get those cumulative 8 points for, and each thing being like 0 to 2 points. And so the things that we watch is we look for tone of the baby and how many times they're moving their arms and legs, how many times they're bending the spine back and forth, the up and down breathing movements of the diaphragm, and then how much amniotic fluid amount that they have around them. And so again, those are all things that babies, we look for them to tell us how's everything going in there. And now you might ask yourself, why do we do that? And so again, this is something that's very time consuming for moms. They may do this once or twice a week, depending on other risks that they have in their pregnancy. Now, if just 35 or older is the only risk they have, they may only do this once a week. But if they also, some of the things that increase with advanced maternal age and pregnancy is diabetes and preeclampsia, sometimes fetal growth restrictions. So there's other things that we have to monitor babies a little closer. And so then you say, if these moms are doing this 1 to 2 times a week, they're spending a lot of time here with us. And so I think it's super important. If you're going to ask that much commitment of somebody, you really want them to understand, why is this important? And so the reason that recommendation is in place is due to increasing rates of stillbirth. And so this is one of the most catastrophic things that can happen to families. And to be perfectly honest, the literature on does antenatal testing prevent that, we're not really sure. We think there is a pretty decent chance that if babies are giving us, or we get an optimal time that we pick up on any signs of stress, that we are able to intervene sooner. I would say that here, we do have a decent number of times through the course of the year that somebody goes straight from testing here right to the hospital to have a baby. And it makes us feel pretty good that, we caught that, and that baby showed us that something was going on before something was really bad. But we really have no way of knowing or giving like a true number of how many things do we catch versus how many things we miss. But what we do know is that 35 or older, those rates do start to go up a little bit. 40 and older, of course, as with most things that we talk about in pregnancy, things go up quite a bit more from that age point on, to include stillbirth. And so that is where those recommendations come in, that we do some extra weekly surveillance on your babies in the hopes that if something is going on, that we catch that. The last and final thing that's really important that we talk to moms about, and again, we don't do this all at one time. We like to kind of start our very first visit and say there are going to be some things that we're going to share with you throughout the course of pregnancy, that we're going to have some recommendations that come along the way, sort of give maybe a brief touch on what those are. And then as the pregnancy advances, we talk a little bit more and have a much more lengthy conversation about those recommendations and what that means for them. But the other thing is a pretty big one, because the way women birth is really important to them, and is sort of the timing of birth. And so currently recommendations are usually, we say, somewhere around your due date. And so anytime from like 39 weeks to like that 40th week, we would like moms who fall into that category of advanced maternal age to be thinking about having a baby. Now, again, it doesn't mean that they have to do that option, but it does mean that we recommend that we go back again to those rates of stillbirth. In the literature that looks at the timeframes in which that happens, 41 weeks, those numbers start to really increase. And so women who are younger than 35, we want them all to have a baby by 42 weeks. Women 35 or older, we start talking about those options versus spontaneous labor or an induction, or if they were planned for a C-section or they've had a C-section in the past, start talking about that time frame for delivery, which generally, again, is going to fall somewhere around their due date or even a little bit before.